Introduce my American colleague, Dr. Collinge. He's joining us from Texas. He'll be giving us 2 lectures before a question and answer session and then a tea break. The first will be on external fixation modalities, traditional and some newer technologies that are based the principles of external fixation but are all internal, as well as definitive fixation of the anterior pelvic ring. Thanks, Cory.
Thanks, Frank, and I'd like to thank you all for letting me be here today. I'm very excited about this. I've come halfway around the world to be here and talk about probably what I like to talk about more than anything in my life, which is pelvic and acetabular trauma. My charge today is to talk to you about stabilizing the anterior pelvis, and we're going to talk about external fixation, and we're going to talk about internal fixation. As Manesh has told you, pelvic fractures are life-threatening problems, and if they're not addressed in a thoughtful manner, bad things happen for your patient. You are likely to be the most knowledgeable person in that trauma bay when it comes to caring for the for the pelvic trauma patient, and if you don't intervene on that patient's behalf, if you're shy, if you didn't do your reading, if you weren't paying attention, bad things can happen to your patient. So you are the expert, and we should all act like it. As we've seen, the pelvis is a very strong ring of bone connected by some of the strongest ligaments in the body, and it takes an awful lot of force to disrupt this ring. The pelvis tends to protect the lower portion of the abdomen and present a foundation for the torso. The take-home point here is that it takes an awful lot of force to disrupt this ring. And be careful of the young patient. As we've seen, our number one goal of treatment is to prevent death, and then we can worry about limb after we've worried about life. The secondary goal, though, is to return the patient to painless function, which really means a well-aligned, stable pelvis. So why operate? It really boils down to 2 things, deformity and stability, and these things are integral to one another. So you can have a badly deformed pelvic ring injury, which is obvious that it's not going to do well. But you can also have pelvic rings that are not so deformed now, but they're highly unstable. They've got diastasis. They're associated with transverse process fractures. They've got avulsion fractures at the pelvic floor ligaments. And these are bad actors. And even though the initial displacement may not be high, these may go on to deform more, creating limb length discrepancies, sitting problems, and mobility problems. And all of this can really lead to chronic pain and become a long-term problem. So when should we operate? Really, it boils down to 3 or 4 situations when we need to operate on the anterior pelvis. And this has been attempted to be summarized, but it's not really summarized well, and it's more of a discussion than a few bullet points. Sometimes we shouldn't operate. So this is a case I treated about 10 years ago. It's a very ominous looking pelvic injury, correct? The posterior ring is disrupted and widely displaced, and the anterior ring is disrupted and widely displaced. But as you can see from the picture on the right, this is a young patient with excellent bone. We got a high quality reduction, and we applied 2 points of fixation posteriorly, but gained a lot of stability. And that pubic ramus has an excellent blood flow and a nice soft tissue cuff and healed very rapidly without any further displacement. So sometimes we don't need to operate anteriorly, even if it's an ugly looking x-ray. As we've seen, another indication for anterior surgery is to resuscitate the dying patient. And Manesh gave a very nice discussion about that. But that's really how the anterior external fixator was pioneered. It was pioneered as a resuscitative frame to save people's lives. And we'll talk a little bit more about that later. The next reason to operate anteriorly is to protect the posterior repair. So as we saw from the second slide I showed you, that excellent strong posterior ring of bone, the arc of bone, the strongest bone in the body, where if it's disrupted, you know it's absorbed an enormous amount of energy. Well, when we repair that, we have a varying amount of stability that we're going to impart on that construct. and sometimes we need to neutralize the posterior repair with an anterior repair. So we've got this extreme case, which I presented here, where there's a highly unstable, comminuted sacral fracture with associated SI joint dislocation and a symphyseal disruption. The posterior sacral fracture was plated, iliosacral screws were applied, and a symphyseal plate was applied to finish out the anterior portion. On top of that, that still didn't seem like enough stability, so we applied an anterior frame. So you've got to make a judgment during some of these cases as to how much stability is enough and how much does your patient need with the injury you're presented with. The next reason for anterior surgery is to help reduce the posterior injury. So a nice example of this is an open book pelvic fracture or a tile B rotationally unstable fracture. You can see from the clinical picture on the left, we've made a fan and steel incision, and we're going to plate the symphysis. But this case was 10 days out, and the reduction was difficult. Even with the femoral distractor, it took some work to shimmy the anterior pelvis into position. Then we went ahead and applied our posterior fixation and an anterior plate in conjunction with one another. And then finally is the classic open book injury, which in case you plate the pelvis to reduce the anterior pelvis and posterior pelvis and treat the partial injury posteriorly with anterior fixation alone. So how should we operate anteriorly? Well, with all the ways that we've just talked about, and we're going to dissect each one of these ways a little bit further. So X-fix, infix, plating, and ramus screws. And we'll chop those into pieces through the rest of this talk and my next talk. So we've got these 4 modalities. What is my algorithm? Can we boil it down to something we can really wrap our hands around? So this is my lecture. This is my discussion about techniques and tricks in my opinion. So you can argue with me, but I can't be wrong because it's my opinion. This is my algorithm. So I make a decision about the patient early on in the emergency room. Are they hemodynamically stable or unstable? If they're unstable, they get a sheet wrap and maybe an external fixator. If they're stable, well then we can just worry about the pelvic ring injury and not worry so much about the unstable patient. So I can go ahead and start my planning for the repair of the posterior and anterior ring. If the anterior injury is a symphysis diastasis, I'm going to think about plating. If it's an unstable ramus fracture, I will consider ramus screws. If it's a stable ramus fracture, then I'm going to probably do nothing. Back to plating. So now I've worked my way down to plating. Now, if there are soft tissue problems, there's an open belly, there's been a suprapubic catheter that's contaminated, there's bad soft tissues, the patient's had radiation in that area, then maybe I don't want to open up the symphysis and plate it, and I might think about other alternatives. Now we go back to around the horn to external fixation, or maybe pelvic infix, which we'll talk a little bit more about in a minute. And then ramus screws, indications are pretty slim, and we'll talk a little bit about that again. But you don't really want to attack the osteoporotic or the highly comminuted ramus fracture with a ramus screw. In that patient, if they really need something, I would go back to plating. And we can discuss further my little protocol, my algorithm, if you will, at the end. So let's talk about external fixation. We talked about its power as a resuscitative device, but it's also used for definitive control of the anterior pelvis. And it's useful as a reduction tool for the posterior pelvis at times. It can be used, as I said, temporarily or definitively, and there's 2 main types of frames people like to use. Originally, there was the iliac crest frame, and we'll get into that, and then more recently, there's the Hanover frame or the anterior-inferior spine frame. The advantage of external fixation is that it's minimally invasive, minimal blood loss, and it's usually fairly easily applied. The problem with external fixation is it poorly controls the posterior ring, and there are pin track problems and problems with mobilizing the patient with these devices in place. And these pictures on the right show this rather nicely. The iliac crest frame was the original frame. It was pioneered in the 1980s and popularized. It was originally a resuscitative frame that was billed as to be applied in the trauma bay, in the emergency room. Feel the iliac crest, make a few incisions, feel the crest with your fingers, drill or not drill, place the pins down the gluteal pillar, and then apply a frame anteriorly and try to control the entire pelvis from the front with a iliac crest frame. As you know, that has not always panned out. And I think the big problem with it is a mechanical problem. So I've tried to demonstrate the problem on the right with this barrel example. So if you have split a barrel and you want to repair the barrel, would you apply the rings at the very top of the barrel? No, you'd move the rings of the barrel down to the middle of the barrel like this gentleman's trying to do. So in this extreme example, we now place pins out the top of the barrel, above the mid-axis, above the top of the barrel, and we try to maintain control of the entire barrel with this frame. It makes no mechanical sense. And that's why you've got cases like the one on the left where there's a frame on, but really no reduction has been functionally achieved. And so this frame has lost steam and popularity. Much more common now is the Hanover frame, or the anterior inferior spine frame, or the supraacetabular frame. It's a 2-pin X-fix, which is usually fairly easily applied, but it usually has to be applied in surgery with a C-arm available. Mechanically, it's much more sound than the iliac crest frame, because it really is at the midpoint, the center of rotation of the barrel. Here's an example of how you would apply the pins. The lower left-hand corner shows you the teardrop or the teepee that's seen on a rollover view with your C-arm, and the C-arm is shown in the top portion of this picture. You roll the C-arm over, see the teepee, and that's going to be the axis for your pin. Through the anterior inferior spine, along the pelvic brim, along the sciatic buttress, and if you really hit a good pin, you can hit it long all the way to the posterior superior spine. And here's a nice example of how you can get a long, beautiful pin in. Manesh mentioned the C-clamp, really of historical interest only at this point. It provides compression of the posterior elements of the pelvis, but there's been some catastrophic complications which have really rendered it useful only in a few centers and not widely used. So really of historical interest, and occasionally useful on the greater trochanters if you want to get a reduction and compression of the anterior pelvis without using an anterior frame. So we've talked about the problems with external fixation. So now we're now in the new millennium, and a new popular way of treating anterior injuries is with the pelvic infix, the internal fixator. So we've now moved the external fixation platform internally and used basically the Hanover frame or the anterior inferior spine frame with pedicle screw implants and moved the frame beneath the skin into the subcutaneous space. So here's Vaidya has popularized this, and he's written several papers on this. You can see very clearly that it's a 2-pin construct, just like the anterior inferior frame. It's a bent rod which attaches to 2 pedicle screws placed in the supraacetabular area and mechanically gives you a nice repair. It also keeps you away from the anterior soft tissues except for the subcutaneous space. It's a minimally invasive procedure, and although that's a little bit relative. So in picture A, there's a skin incision probably about 1 inch in line with the axis of the screw through the anterior inferior spine. Dissect down to the inferior spine, incise the fascia, and place your screw along the sciatic buttress. Then you're going to make a tunnel with your pre-bent bar. It's a 6 millimeter bar in most cases. Apply it through the subcutaneous tunnel beneath the skin, and you can feel your way across as you apply it. Attach it to the pedicle screw grommets and cinch the whole thing down while doing a reduction in conjunction with your reduction. And this is a summary slide going through those individual parts. Vaidya has reported excellent results using this method. So his first series, they all did great. They had anticipated that everyone was going to want these frames out, and as it turns out, only about half the people came back and thought it was worth their while to have them out. So not all the frames have been removed, and people seem to tolerate them reasonably well. Very low complication rate in the literature. So now I want to, again, spin back to my experience. So this is a case of a 57-year-old woman. She was in a high-speed motor vehicle crash. She was ejected from the car. She has this unstable vertical shear type pattern. She has a straddle injury anteriorly with bilateral rami fracture, superior and inferior, and a vertical shear fracture in the left side posteriorly. You can see from the inlet and outlet views that it's mostly a sacral fracture, but it does involve some of the inferior elements of the SI joint. And here's the corresponding CAT scan. And you can see from the picture on the left upper corner that it does involve some joint, but mostly the sacral. So this woman is 57. She's had a hysterectomy, which dehyst, became infected, was cleaned up 4 times over the span of about a year. She was ultimately treated with 3 reconstructive procedures, including mesh, right where I would like to do my anterior pelvis surgery. So this does not seem like a great place for a long plate, and this seems like a reasonable case for either an external fixator anteriorly after repair of the posterior portion, or a pelvic infix. So she got a pelvic infix. This is the post-op AP radiograph. You can see that the articular reduction is not optimal. It's not perfect, but I think the sacral fracture is well aligned, and you can see that reasonably well in the inlet and the outlet views. And she did very well in the early post-operative period. She mobilized at about 3 months, got back to ambulating, and went back to work as a jewelry salesman in a clothing store, which is when the trouble started. So she returned to my office with a late femoral nerve palsy, talking about anterior thigh numbness of new onset and weakness in her thigh, and she had a new onset limp. A late femoral nerve palsy? What does that mean? Well, it may mean that I put my frame too low and have impinged on the femoral triangle, which was at the initial discussion by Vaidya not discussed. And they've just come out with a paper now saying, okay, we need to put the the screws with some buffer zone. So somewhere between 2 and 5 centimeters off the anterior inferior spine. So keep them proud and keep the bar from impinging on the fascia, which I think makes good sense. In the meantime, I've talked about this case around, and I've had people pull me aside at meetings like this and tell me, oh, hey, I've got one of those too. A couple of my friends of mine have bilaterals, including one with arterial embarrassment that had to be rushed back to the OR and have the frame removed. So we now have a small case series, which I think, in popularizing this little problem, have gotten the original authors to reevaluate where the pedicle screws went and how deep that bar must sit. So think about that if you are engaging the infix craze. So in our discussion, we discussed the infix as a very clever way to deal with some of the external fixation problems by moving the construct internally. But it's not for every patient. Complications are not well defined, and the new femoral nerve palsy is a doozy, and you really don't want to be dealing with this. And I think in general, pubic symphysis plating still remains the gold standard for anterior fixation. Okay, thank you very much. If we can load up the second, we'll talk a little bit more about internal fixation.